Okay, thanks. So Heather, myself, and Karen will be doing this part of the presentation. So Heather will get started.
Okay. So if you
Next
can
slide, please.
do the next slide, that'd be great. And so yeah, just to give you an overview of what we're going to be presenting today, we'll be talking about a pilot project that has come out of some of the work that we're doing, as well as just ENT program, the Transition Navigator trial. So, but our part of the presentation is really about a transition project, pilot project that we're doing here at the Stollery. So back in 2014, our Patient and Family Centered Care Council identified transitions of youth to adult care as a priority initiative that they would like to discuss with our senior leadership more. And at that same time, I know that Dr. Mackey had been talking with senior leadership as well as other people from our ambulatory clinics, saying that we really need to do some work in this area to create some standards and some ways to further our work in transitions of youth to adult care. So at that time, I also remember Deb Thul reaching out to us and wanting to share some of the work that Alberta Children's Hospital was doing. And so we had a meeting of some of our staff, some of our members from our Patient and Family Centered Care Council, and I think Dr. Mackey was there as well. And we really created a bit of a working group and also a steering committee of our Stollery leadership at that time to really create some stronger commitment to moving this work forward. So at that time we also did a survey of our different clinics at the Stollery to find out kind of what resources they're using, what are they doing, what do they consider the age for transitioning adults to pediatrics, or from pediatrics to adults to be, and a whole bunch of questions, and really discovered that we're doing something different in all the different areas. There's some, certainly common understanding of the need to do this work, but not a standard approach at all. So that's when we were fortunate enough to get to host this transition symposium in March of 2015. That's where we had a number of different practitioners join us. We had 98 participants from our pediatric programs, and 30% of those people were from the adult programs, and then about 13% of those were actually young adults or parents who've been involved in transitioning. And then in addition to those 98 participants, we also had about 58 participants attend via telehealth at 6 different sites across Alberta, mostly Calgary and Edmonton. And we received a lot of feedback from all of these people. So some of them were from the adult world, and most of them were from the pediatric world still at that time. And so from those, from that symposium where we had Good to Go present, we had On Track present from BC, and also Well on Your Way from Alberta Children's Hospital. So they each presented, and then we had different working groups at that day, or different tables, identifying what they felt were some of the strengths of each of those programs, what they wanted to see the Stollery or our Edmonton area looking at continuing on. So the recommendations that came from that day were we need to find some funding for dedicated staff, which we'll hear more about later on in our presentation, to really identify the scope of the initiative, which we were really wanting to focus on for this particular project to be an Edmonton zone based, but knowing that that would require us to collaborate with adult care providers across the health system, as well as young adults and parents. Also, one of the things that came out clear is that there's a lot of confusion about the transition process and the age in which we start to engage youth and families in that process as compared to the actual date of transition. So that was a good point of clarification, because there's a process and then there's a date when the care is actually transferred. Defining our philosophy, which you'll hear a bit more about in our framework, and the importance of engaging our primary care providers and community providers in this process as we move forward. We also recognize the need to access our IT department and the technology that we need to have online resources, the potential for creating apps, and also the benefit of electronic medical records. Another key recommendation was to do research, which is something that we'll be hearing more about here, and then piloting the transition approach that we have developed here with a limited number of clinics, and then to build capacity over time with a broader number of clinics so that we're supporting the staff to do their work in a more intentional and effective way. So I think that gives you a bit of a history of how we've come to this point today. So the key objective is really the definition that we've adopted from the Canadian Pediatric Society, and implement a transition program consistent with that, and address the needs of adolescents and young adults in our northern Alberta area that we serve. So I think most of you are probably pretty familiar with this definition based on your work with this community of practice, so I'm not going to go any further in reading it, but I think you're very familiar with that objective.
All right, so just a little bit of information on the framework and the flow chart that we put together in an effort to develop a straw dog model for this initiative. So the framework included I guess some key components like the philosophy, what are the health indicators we're looking for, and what will be the guidelines for transfer of care. So for the philosophy, we wanted to set some fundamental principles for the work that we will be doing, keeping in mind key things like transition is a process, not an event. The adolescent is the most important part of the transition process. The mental health piece, the chronic disease management piece, and so on. For the transfer of care, we in alignment with the transition CAPHC transition guidelines, keeping in mind that transition is a formal process that begins by the age of 12 and also includes transfer of care for us here at Stollery at approximately the age of 17 years. Based on the admission criteria. For health indicators, so next slide please. For the health indicators, we had three things in mind. So we wanted to ensure transfer from pediatric to adult care clinics, the chronic disease management component, as well as the access to a primary care provider. So we had some of the key information in the framework, and we can share that offline if anyone is interested in having a look at that. And the other piece was the flow chart. That's on the next slide, and that's just looking at steps that will need to take place along the continuum. So what happens at age 12, 13 to 14, and some of the key steps that would need to be completed in pediatric care and also in adult care. So we put together this model and with the goal of piloting this in one clinic, first of all, to see how things go before we scale this up to other ambulatory clinics. And Karen will talk about the pilot project in the diabetes clinic next. Karen?
Yep, so next slide. So I started this clinic in 2008, so I'm a nurse practitioner. I see 150 patients per year, and I see them approximately every 3 months, or if they start at 15 and a half, they get 6 appointments. But there's also weekly drop-in clinics with a nurse, a dietitian, a social worker, phone, fax, email, lots of ways to get a hold of us. And I transfer them at 17 years of age, and after that they usually have 1 or 2 visits per year with adult health, and they have an access to a certified diabetes educator, an RN or an RD. They send me a letter back, so this has worked out really well in Edmonton. Other areas it's not working quite as well. Next slide, please. So one of the biggest things that we were working on was trying to understand how clinics were working currently, and although I had good contact with the adult center, there was a lot of information missing. So I started a Navigator database where I see every clinic patient gets put in with their date and what their current A1C is, and when they're transferred to adults, and if I get a letter back, that's put in as well. We had combined pediatric and adult meetings, which was one of the most important things we did, and we did a clinic readiness assessment. Next slide. So the clinic assessment was done by a social worker who went both to pediatrics and adults and observed them for a day to see what they were doing. And we came up with kind of a checklist. So did they talk about sexual health? Did they talk about family physician? The other thing we did was the adult RNs would attend a half-day clinic with me, and I attended a half-day clinic in the adult program just to really understand the differences. And that really has facilitated better communication. They contact me if they don't show, or I can contact them if there's some issues or a really difficult kid. Next slide. So we also want to know what the experience is of both the pediatric and adult healthcare clinics. So we want to know, does our framework, does our transition process work? What are our barriers? What do we need to change? So that's what we're currently evaluating. We also want to figure out what do we need to build in terms of capacity, such as mental health. Adults really doesn't have a good access point for those patients. And how do we continue to build on our framework? So that's kind of in the process, and right now we're not doing this piece. It'll be at the end where we'll do more of a healthcare focus groups. Next slide. So the evaluation we're using is the Am I on Track questionnaire, mainly because I wanted something to target parents as well and not just the youth. A satisfaction survey is given at the last appointment, and it's looking at the resources that we're providing on diabetes, the process, support resources. And this clinic really is not just about transition, it's also about self-management of diabetes care, because a lot of people end up very poorly controlled, poor knowledge, and so we're really trying to help that. So we do an experience survey after the initial visit to look at how does the patient think about transition as a whole. Next slide. So the information we're collecting is number of clinic appointments in pediatrics and the interval between the last pediatric clinic, first adult clinic appointment, number of no-shows or canceled appointments. We're tracking BMI and A1Cs, which kind of gives us an idea of chronic disease management. And these kids are at risk for higher rates of obesity and then other complications. Emergency visits, hospitalization, and mortality rates. So we do have kids that pass away shortly after they see us for various reasons. Comorbidities, presence of diabetes-related complications, and geographic location, because we see people from as far away as Northwest Territories, BC, and not so much Saskatchewan anymore, but just occasionally. Next slide. So basically, this is all we've talked about. It's still in the early stages. We've got about 5 months worth of data, and at present 3 surveys for the satisfaction part of it. So we're really in you know, maybe 25% of the assessment is done. Next slide. All right, Glenrose, you're up next.
Okay, hi. It's Gail speaking, and I've had the privilege of both working with the development of the CAPHC guidelines as well as being on the Stollery steering committee and here at the Glenrose. Just next slide, please. The Glenrose is a freestanding rehabilitation hospital, and we do have both adult and pediatric services on the same site, so that enables part of the transition. When we developed our transition framework and practice, we did the usual literature review and benchmarking, and came up with 3 principles that framed what we were going to do. So our three practice principles were that we have patient-centered care, and that means both youth and their caregiver. The other is capacity building, both training our staff in the pediatric area as well as the adult side, coaching the youth and caregivers, empowering them with information about their condition and advocacy, and also coaching community resources and building those collaborative bridges. And our final principle was looking at navigation, providing a navigator, a person or resource to help in any of those speed bumps along the way. So at the Glenrose, we deal with two different populations. We have a neurodevelopmental disability, but neuromotor, including spina bifida, cerebral palsy, and our neurodevelopmental side, including such conditions as autism spectrum disorder, focal spectrum disorder, and individuals who have intellectual disabilities and complex learning disabilities. We have taken a lifespan, life course perspective because of the chronic and developmental disability needs of this population. What our goal is to establish that optimal independence, or if need be, an interdependence, shared decision-making, depending on the capacity of that youth to make the transition into adulthood with independence. We spend a lot of time empowering the youth and caregiver by giving them knowledge and skills and what they need to look at sort of growing up to be an adult. We focus a lot on self-determination and personal goals, whatever their competency is, that being patient-centered, that each person has an opportunity to express in whatever their cognitive and communication or executive function limitations are, what they want. So with that engagement. Next slide, please. Look at two types of transition. One is the medical transition, and focus on providing a transition to adult primary care as well as to adult subspecialty care to provide for the health and rehabilitation needs and provide a lot of training of those service providers. And as I mentioned, we are fortunate for some of our conditions that subspecialty care can be within the same rehabilitation setting. But for individuals who live, because we also serve central and northern Alberta and up into the territories, to help look at developing that capacity within closer to home in their own home communities. But we spend a lot of time focusing on social care, and that is the support to that young person to grow up to be an adult. Our benchmarking and what's in the literature, the international classification framework really defines what we're doing. And I think most people on the call are quite familiar with the ICF, but it focuses on more the impact of the medical condition, but also the goal is successful participation in life. So we look at all aspects, both community participation, the education and employment opportunities, housing adaptation, relationships, and the sense of belonging, financial supports, mental health issues, and stressors. We're not as far along as the Stollery is in having good pilots established and looking at different outcomes. We're doing a variety of evaluations, but the evaluation needs to look at both the health outcome. For example, is the young adult able to access their equipment needs and their rehabilitation therapy, or access in, for example, somebody with autism, an adult-specific employability program. It's difficult to measure those softer quality of life measures. Often the measurements are done from satisfaction surveys, both from the perspective of the individual who's transitioning or their caregivers, as well as the staff. So I think we have a long way to go, but we're really well on our way. So I'll turn it over to the next presenting group. And I guess that's us. I'm Deb Thul. I'm, as I said, the Adolescent Transition Coordinator at the Alberta Children's Hospital. And I'm presenting just briefly what's happening here at Alberta Children's Hospital in terms of the transition project. So I'm presenting with Suzanne Libbey. And I'm really only going to present the first slide, which talks about why, our current state and why we are moving forward with an additional project here related to transition. So I'm not going to talk about the transition coordinator and the model of care because most of you are familiar with that who are on the call. But what we identified some gaps and some barriers in the transition process. And so that's the reason that we are developing this new transition project initiative. And so some of the things that we've identified as problematic is that we can't easily identify how many youth or who the youth are who are transitioning to adult care. So you know, each clinic, you know, knows they're transitioning patients, but once they leave here, we don't really have any way of tracking who they were and where they left and whether or not they showed up. So we can't measure or monitor what the outcomes are. So we really want to have a way of identifying them pre-transition, you know, and ensuring that we're preparing them well, and then measuring and monitoring outcomes over time. And we do have transition tools and resources and websites, and we have, you know, and I think all the clinics here at Alberta Children's Hospital are engaged in some way in transition initiatives, but you know, it's not equitable. Not every clinic is doing the same thing. Some are doing an amazing job of preparing patients. Some are just doing the basics. And so, you know, the roles and responsibilities for transition are not always clear between the clinics. And there's not a lot of equity always in terms of what's happening related to transition. And all the clinics do not really have a clearly identified transition preparation pathway. And so those are some of the things that we hope to address in this new transition project. So I'm just going to turn it over to Suzanne now, and she's going to talk a little bit about the project. So if you move to the next slide, Lisa, that would be great.
Thank you. So we're very early in our project planning stages, although work on transition has been going on for several years here at the Children's Hospital. So what we're looking to do is identify some site-wide transition documentation and build it into our electronic medical record system. So we want to know how we can identify and screen, so we know the types of kids and the number of kids that need help transitioning to adult care. And we also want to support ongoing processes and outcome monitoring through the electronic documentation. We're also looking to work with clinics to identify and implement preparation pathways and identify opportunities to enhance all of our clinic transition programming. And then obviously we want to be able to operationalize and sustain all of this work going on into the future. So we're looking at a multi-year project, and if you move to the next slide, we are currently just at that, this is our model of care that we're working with, so we're really focusing on that first preparation in the blue boxes. So making sure that we prepare patients for the best transfer and transition possible.
Lisa, if you just click it, it will show the focus for the project.
There we are. That's our transition focus. So that's what we're really putting most of our effort into at this time. And if you go to the next slide, so our next step, so we have a core project team, which is mostly sitting in this room, and we're just developing our project charter, identifying our scope of work, exactly what are our deliverables, and divvying it up into a timeline over a couple of years here. And moving on to our next transition team. You're up.
All right. So I'm Susan Samuel. I'm a researcher, a clinician scientist here at the University of Calgary and a pediatric nephrologist. We have been working together with a large number of stakeholders in Alberta for several years, and it has culminated in this project that I will describe to you. Now we are just doing the preparatory work, and it should be up and away hopefully in the fall. So if you can go to the next slide. We talked about the primary problems with transition, and the major problem is variability in care and fragmentation of care. And the big thrust of our research project is that these problems are really big and cannot be fixed in silos or individuals in specific departments. And the solutions are definitely complex and multifaceted. But as highlighted in the CAPHC guidelines and other qualitative literature, there are very few RCTs evaluating the effectiveness of interventions to improve patient-level and system-based outcomes during transition. Go to the next slide. We also conducted a transition symposium in 2012 and created a report with specific recommendations on how to improve care within the Alberta context. And some of this work has been informed by that symposium in the past. Go to the next slide. We talked about this model of care for transition. So Lisa, if you can just click one more time. The project that I'm going to be describing is going to focus in the adaptation phase of transition. But we talked about the preparation phase happening at the ACH, but really we're interested in providing interventions to support individuals after they have left pediatric care. So to the next slide. And we took a very careful read of the CAPHC guidelines, and it was very timely when we were developing this project into its full form. The guidelines were released, and we used those guidelines to inform the intervention as well as trying to sell the project to the funders. So next slide. And at the same time, a very timely piece of operational leadership that came into being here within Alberta Health Services are the strategic clinical networks. The basic premise of strategic clinical networks is to bring clinicians, researchers, and policymakers together working on a clinically relevant problem to improve quality, increase cost savings, and to do things in a better way. And our little strategic clinical network is not so little, but the pediatric strategic clinical network is called MINCI. It stands for Maternal Newborn Childhood Health Strategic Clinical Network, led by David Johnson, and they set some priorities. You can't really see it, but the red oval shows that transition of children with complex needs is one of their priorities. So this particular Alberta Health Services group really gave us a big boost to bring this project to the full grand stage. So advancing to the next slide. So we feel that the time was right, that we had the right question, the right place, being AHS with a unified health system throughout Alberta. And we do feel that we are testing the right intervention after extensive stakeholder engagement over several years. And we obviously had great team and environment. So I'll just briefly describe what we are planning to do in the next few slides. So our first activity in this, what we're calling the Transition Navigator trial and related work, is some pre-trial baseline work. We have a qualitative investigator who's joined the team as one of the principal investigators, Gina Dimitropoulos. She's a social worker with extensive experience in transition age youth, in particular mental health. So she's going to do some baseline stakeholder interviews as well as focus group with families. And our goal here is to get some contextual information. We have a lot of this already. However, we didn't take the systematic route of research questions and publishing that result. So we're going to redo this, I think, very shortly. This work has been approved by ethics, and we'll undertake these interviews. We're going to focus on particularly the ethical, legal, and policy aspects of transition, which has been identified as a source of frustration for many families. To go to the next slide. The next activity is We're going to work with a historical cohort of patients. First, we're going to identify them using Alberta administrative data held by Alberta Health Services. We will create an algorithm to identify these patients within these data sets, and then use that algorithm to evaluate how they utilize care and also assess costs associated with transitioning youth. So costs before, costs after, costs of specific service utilization. And we would like to create some sort of atlas to inform our policymakers about the burden that this population imposes upon the health system, as well as their outcomes. And the next slide shows the major activity, which is Transition Navigator Trial, affectionately called the TNT. It's a mixed methods RCT. Our primary outcome is emergency room visits. Our intervention is a patient navigator service, which will be operational in the adult space and time period. And then we will also do an embedded qualitative study to understand the contextual variables affecting the transition period, evaluate patient experience and satisfaction using qualitative methods, and also do a cost analysis. And we're going to find out what the navigators did and what they did, if it worked and why it worked, and if it didn't work, why it did not work. So it's basically an embedded qualitative study that will inform us better about how the navigator system or service will improve, or if it didn't improve care. So the next slide. This just shows you the basic design of the study. We're going to consent patients as they come up for their transfer to a subspecialty care. There's still some negotiations about whether children who are going to primary care would be included. We'll do some baseline interviews, randomize them to a navigator arm or a control, which is usual care, and then evaluate the primary outcome, which is emergency room and ER visits after transfer. And we will conduct post-trial interviews with focus groups. Initially it was thought just the navigator arm, but we will do that for the control patients as well. And we'll go to the next slide. This just shows you the diversity of clinics that we're going to target, because the important advance that we're making with this study is that we're testing a system-level intervention in real time in the real system, which is a broad inclusion criteria, and we can pull patients from all these clinics at the 3 major pediatric hospitals in Alberta. So it's a population-based study, and this will improve generalizability of the results, because prior studies have been single center, single setting. So to the next slide. We're aiming to recruit approximately 300 patients in each of the arms, the intervention and usual care. For the navigators, it would be about 150 patients each, 140 in Calgary and in Edmonton to be serviced by the navigator service. So next slide. And finally, we have engaged various stakeholders throughout the implementation of this trial. We will continue to do that during the study. We need to advertise the study more, and that one of the reasons we're presenting it in this forum is to let you all know that we are undertaking this particular project here, and we will be disseminating key messages as they come through. So the next slide. We have received some funding from the Alberta Children's Hospital Research Institute through our foundation, as well as through the Alberta Health Services and our MINC Strategic Clinical Network. And just this week we received a competitive grant from CIHR. We were very close to receiving full funding and just missed out by 1 rank, but we did receive bridge funds from CIHR. So we have sufficient funds to launch this RCT in the fall, and ethics and other preparations are underway. We are with AHS regarding navigator roles, and these discussions are happening in synchrony in Edmonton as well as in Calgary. The Edmonton work is being led by Dr. Mackey, who's on the call, and Heather McCrady, who is the administrative lead for this particular work, who's on the call as well. If you can go to the final slide, this just shows you the number of people that have been involved in bringing this project together across Alberta, and we are sincerely grateful to all of them as well as the funders. So we'll just end it there, and we have lots of time for questions, and maybe we can just cycle through the presenters. Maybe questions for Stollery first.
Alrighty, thanks very much, everybody. I won't go through everybody's names again. Does anybody have any questions or comments for any of the presenters, or about the project in general?
I had a question. It's Gilles Chano from Children's Hospital in Ottawa.
Yeah.
I can't remember the name of the person, the nurse practitioner who presented on the diabetes transition. My question is, I saw that when the youth was 17 years old, you would look into making 1 or 2 appointments with the adult physicians. And I was just wondering, how are they reacting to my thoughts is that they have a bigger population with diabetes to deal with, and how are they feeling about accommodating a 17-year-old into an adult appointment, and what's their buy-in, and are they supportive? Are they very open to it? I'm not too sure if you understand the question.
Kind of. Sure, it's Karen Johnston. I'm the one who was talking. You know, there's a lot of physicians over there, so it's a little bit variable. So I think if you talk to different physicians, they probably have different opinions. But having the communication going back and forth, I think, has really moved things along. So we had to have a lot of discussions about what a 17-year-old was really capable of doing, and that they're not an adult yet. And the director and I sat down and I said, look, if your 17-year-old was going to their first clinic appointment in adults, would you go with them? And he said, yes. And I said, then we shouldn't expect in diabetes that parents aren't going to come, because that's always kind of one of the issues. And so I think that's kind of been evolving, and it's getting better. They certainly don't have the capacity to see these kids as often as they should, because, you know, with type 1 diabetes, it's really about what you do to manage it rather than what we do for you. And things change so quickly, right? So yeah, they don't have capacity that they need to see these kids as frequently.
But just the fact, Karen, just the fact that they're accommodating 1 or 2 appointments, I'm very impressed by, to be honest with you. Love to have someone like that in mental health, but at the same time as being able to accommodate this population and making the time and recognizing the complexity sometimes of the medical issues, I'm really happy to hear that.
Yeah, me too. I think the biggest issue with type 1 diabetes is these kids don't have complications yet, and their focus is really working with the highly complex diabetes with lots of complications, but prevention is a huge part of this too, so I agree.
Thank you.
Anybody else? I could go down the list and just ask if anybody, so that we're not talking over each other, if you want. Andrea, did you have any comments or questions?
No, I'm just pretty much taking this all in as we start to create a transitions clinic here. So I appreciate this. Maybe if I could speak to Karen one day about the NP role, that would be really helpful for me as a pediatric NP.
Excellent.
For sure.
Bianca, any thoughts from down east? No? Okay. Brooke?
Hi there. Thank you so much. That was very, very informative and lots of exciting work going on. Again, I don't remember who it was who spoke specifically about this, but I'm just wondering about some of the patient satisfaction surveys or tools that you're using both pre and post transfer to adult care. I think it was one of the first 2 speakers who mentioned that. I'm just wondering what kinds of questions you're asking.
This is Heather from the Stollery. So we could certainly share that with you. rather than trying to explain it all here. So it's who again that was requesting this?
Brooke Alamang.
Sure. Heather, if you just want to share it with me, I can send it along to Brooke or to others if they're interested.
Thank you so much.
Yeah, I think that there was some interest here at Alberta Children's as well, so if you just want to send them out to everybody, Lisa, that would be great.
Okay. And
there's going to be 3, I think. There's one for parents, one for adolescents, and then one in the adult program as well.
Okay, perfect. And is this so you're just sharing the tool itself, right? Not any data?
We really don't have any data. Like I said, I think there's only about 3 that have been completed because we just recently did this.
Yeah.
And that it's a fairly in-depth questionnaire. It's probably a little longer than we would have liked, but we're trialing this, so we're going to see how it goes.
And I'm just wondering if that's something that could be shared on our transition tools and resources page as well. Just think about that if it's something that you're ready to share that broadly. So you can let us know. Right, Arlene, did you have any thoughts or?
Yes, thank you for presenting. Looking forward to the results. I know that there'll be a while yet, but I was wondering about your consideration for the transition navigator position. What are you looking for with respect to role qualifications?
Yeah, so I think that's still up in the air in terms of exactly what we're looking for, and we're talking with operational people here at the Children's and operational people at the Stollery and trying to clearly define what the role of the navigator is. And but it definitely needs to be somebody who understands and knows what resources are available and can help build patients and families' capacity to navigate and access the resources and services that they need, and ensure that they're showing up for appointments and have self-management, self-advocacy skills. So it's going to be a range, I think, of exactly, but we haven't hammered out the role. Now, Andrew's on the call, and I think Andrew and Karen have also been talking about that, so maybe they have something more to say.
It's Andrew Mackey here from Edmonton. So in terms of the training background that we are going to be looking for when we hire navigators for the Transition Navigator trial, we've decided that the ideal clinical background would be that of a social worker and somebody who's experienced working with adolescents and or young adults. The exact elements of the intervention are still being worked out with input from Karen and others, but will include communicating with pediatric and adult providers, facilitating having a family doctor, facilitating making appointments on the adult side, facilitating with issues like insurance claims, and being a resource and a go-to person for whenever questions come up, and they'll be accessible to study participants by a variety of forms, including, or by a variety of methods, including cell phone, not using personal cell phones, of course, but study cell phones, and email. And yeah, that's a bit of an overview, but it's still a work in progress.
Yeah, and if anybody has definitions they're using for navigator or transition coordinator, if you wanted to send those in, I'm finding it is not very well defined. It seems to be a pretty loose term out there.
At the Glenrose Hospital, in our spina bifida clinic, we are currently using our social worker as the navigator to support the transition. And one of the things, the learnings, is that individual has to be given the protected time. It's not an add-on job. It must be. It is quite demanding, especially if the youth and the young adults uses the Navigator to keep looping back in when things aren't going smoothly.
Oh, absolutely. So for the Transition Navigator trial, there will be a navigator on the Edmonton side and a navigator on the Calgary side, and they will be full-time positions dedicated to the study.
Thank you for sharing that. It's Arlene again. I wondered, I guess the one thing that's got my brain going is around if there's a clinical issue that arises, is the role of the transition navigator obviously having sort of one foot on one side and one foot on the other side. It's obviously going to be linking that. I think my understanding and my current experience shows that there are some elements of medical clinical issues that blend into obviously the self-management piece and insurance forms. So it to me is seemingly a challenge to define, as you're saying, a transition navigator, to blend sort of two roles in one. And I come from nursing. I'm a nurse practitioner, so I'm just giving you my lens around the challenges that I'm currently experiencing in this current transition population.
It's Susan here. We appreciate that comment because this comment has come up several times, and we've had to define the workspace for the navigator, like the virtual space. And the question is the question of the distinction between management, case management, or medical management, and more of a coordinator navigator role. The role of this navigator, as we're conceiving it, will be outside the medical team. And they have to be in order to advocate for the patient. But when there is a medical issue, they will find ways to overcome those issues by linking them back either to primary care or to the subspecialty care. The navigator, as we have conceived it, has to be broad in scope. It cannot, he or she cannot be embedded within one clinical setting. So there's going to be some gray area where the navigator role will blend into the clinic case manager role, but we don't want to go too much into that area. But the navigator will remain outside the clinical space. That's the way we're trying to draft the intervention.
Thank you.
Thanks so much. Dania, did you have any? We're getting to the top of the hour, so just if people have some questions or final comments that haven't been shared yet.
Hi, Lisa. This is Deb Thul. Jeanette had a question here for Stollery.
Just wondering, you mentioned quality of life, and wondered if there was a specific tool that you're using to measure quality of life.
We are not measuring quality of life as part of our ongoing survey. It's just the satisfaction survey is really looking more at, you know, did they think what we're doing is of value? So I'm calling it death by survey otherwise, because, you know, we're giving out a lot of surveys over a 2.5-year period of time.
Thanks very much. Then I guess I'm just wondering, is anyone else across the country using any quality of life measurement for transition? At the Glenrose, we're currently exploring possible tools. We're actually have another little navigator project on the go as well. And currently what we're doing is more direct communication with the youth, like an direct interview process rather than another questionnaire. But I think this is an area of needing further research to find a tool that is useful to give us that information without overburdening the young adult with yet another piece of paper.
Actually, this is Lisa. I have a sort of a quick question about how you're going to aside from all the surveys and sort of the satisfaction type of things, but sort of the outcome data and all of that clinic visit data, how are you managing that? And like, are there connections? I realize you're one big health service, but do all of these systems speak to each other, or can you transfer this information easily? Or
we're laughing here.
I know you are. I know it's a silly question, but it's just, I'm just wondering how you're going to do that.
Yeah, so actually, you know what? I think Alberta has an advantage in this area. Yes, we are fragmented in terms of electronic health records between Edmonton and Calgary, but in the future there is a one system coming.
Okay.
But this trial probably won't last till that system is up and going. But we have a neutral party. Even though our electronic health records don't really communicate, we have a neutral party which is called Alberta Health Services Clinical Analytic Service. If any of you know ISIS in Ontario,
yep.
This is a different version of such an enterprise, but not set up for research, but set up for informing health service delivery for internal Alberta Health Services purposes. But we as researchers have access to this enormous data holding, and they hold a large segments of even the electronic health record, so things that are entered into what we call SCM here, as well as Edmonton's eClinician. We can have access to that, as well as all the inpatient hospitalization data, the emergency room visits, urgent care visits, even a little bit of laboratory and pharmacy data. So I think this work is much more feasible in Alberta than it would be in other jurisdictions, just simply because of Alberta Health Services. And we've taken a lot of pains to have Alberta Health Services Analytics team work with us on this project, and this will be one of our first deliverables. And it should be very doable.
That's great.
With our Stollery pilot project, this is Heather speaking, we've engaged evaluation services, which is kind of a fee-for-service department within Alberta Health Services. And so with the support of some funding through our Stollery Children's Hospital Foundation, as we progress with this work, each quarter of our year they'll be producing a report of the surveys and all the data that they've been able to acquire. So that's going to be really helpful for us as we move along.
Heather, we were just saying that it would be really nice to know how you engage them and whether we can do that here in Calgary. Because I wasn't quite sure, it's Susan, sorry, I wasn't quite sure how to engage them. We tried to contact them in the context of this study, but I think broadly for our project office who's trying to roll out some of these innovations, that would be very helpful. So if you can share that with Deb Thul.
Yep, for sure.
Thank you.
Alrighty, so we're at the top of our hour, and I guess we'll defer Andrew's discussion about some of the data that we've been able to pull from CAPHC till our next meeting. Thank you again, everybody from Alberta, for sharing what you're doing out there. If anybody else on the line, we didn't get to everybody for questions and comments, but if you have some, just send your questions and comments to me, and I can forward them to the team in Alberta, and we can continue the discussion that way. So this presentation was recorded, and it will be posted on the Knowledge Exchange Network with the rest of our transition presentations. And again, we'll share that those surveys from I think the Edmonton team, and we'll be in touch between now and our next call. So thanks again, and have a great afternoon.
Thank you.
Thanks, everyone.
Bye-bye.
Thank you.